Hello, I am Ashok Srinivasan from the University of Michigan. Our next speaker will be Dr. Mailan Ho, and she's a clinical associate professor of radiology and the director of research, as well as the director of the Advanced Neuroimaging Core at Nationwide Children's Hospital in Columbus, Ohio. Her topic will be zero time echo MRI. Can it replace CT?
Greetings, everyone. Today we'll be talking about zero TE MRI. Can it replace CT? I'd like to acknowledge my various grants, several of which supported the research work you'll see in this talk. I'd also like to acknowledge several people from various groups for their assistance and support in this project. Today, we'll be discussing the fundamental techniques used in bone MRI, illustrating pearls and pitfalls of clinical interpretation, and evaluating emerging applications in head and neck imaging. So first of all, technique. What is this? Cortical bone is a very dry tissue. It has very few mobile protons, and they decay very rapidly following an MRI pulse. So in order to capture appropriate signal from bone, we have to do a very fast readout using a very short TE, or time to echo, relative to the pulse excitation. Over the course of MRI history, we have progressed from gradient echo with TE in milliseconds to ultra short echo, and finally zero echo with less than 20 microseconds TE. You can see the concomitant improvement in the delineation of cortical bone. By nature, these sequences are rapid and high resolution. They're also relatively quiet and resistant to artifacts, including motion, susceptibility, and flow. In terms of workflow, there are many different vendors and platforms offering some version of ultra-short echo MRI. We prefer 3 Tesla for most of our applications, although in certain instances, 1.5 or 7 Tesla may be preferred. These sequences should be compatible with the standard head coil, and the sequence time is typically around 2 to 4 minutes. It depends on what field of view, spatial resolution, and ASHNR you desire, but typically you can achieve a 1 millimeter spatial resolution in about 2 to 3 minutes. We can vary some fundamental parameters in this sequence. We like to keep our flip angles low so that we have minimal time to measurement. With a flip angle of 2, you can see that there's still some gray-white distinction and the fascial planes, whereas at a flip angle of 1 degree, the soft tissue contrast is now very flat, but the bone pops out more. We can also run some other tricks. For example, off-resonance excitation will blur the fat-water interfaces so we don't see as many of the fascial lines, and that can be done with either flip angle. So because this is a radial acquisition with phase oversampling, we can actually post-process the data to extend the field of view beyond the originally reconstructed data set. So on top, I have the original images covering the bones of the head and upper face. And in the bottom row, we now see that you can post-process the data to extend coverage to include the structures of the neck. Using this approach, we can further decrease off-resonance effects, increase spatial resolution, and/or decrease scan time. There are a multitude of additional sequence options, which can include pre-pulse preparation, gradient modulation, multi-echo acquisition to achieve quantitative tissue classification, and other ancillary features such as fat-sat or motion correction. One important consideration is coil loading. So if you have a small head or it's asymmetrically positioned in the coil, you can frequently get these shading artifacts, particularly along the periphery of the head, where it looks darker intensity in the center. And so by performing intensity normalization and bias field correction, we get a much more homogeneous image across the field of view, which can be used for post-processing. Ultra-short echo techniques have many diverse applications beyond cortical bone. Other short T2 tissues would be cartilage, ligaments, and tendons, so musculoskeletal MRI is a big application. Also lungs and airways for chest MRI. You can even add an inversion pulse to achieve T1 weighting, thereby enabling myelin imaging and MR angiography. In terms of broader utility, these techniques enable one-stop shop MRI so that you can evaluate both soft tissue and bone pathology with a single modality. You can also use this for PET attenuation correction. So for PET MRI, we can reduce dose without having to use CT to calculate bone density. Finally, we could potentially use this for planning interventions such as radiation therapy or surgery. Now for interpretation. How do I read it? One of the best indications for a ZTE MRI is the infant with abnormal head shape. In this setting, the clinicians and parents are looking for some reassurance beyond the physical exam, but they're often not willing to pull the trigger on ionizing radiation. Unossified cartilage in sutures and fontanelles has a short T2, but it's still longer than ossified bone. So essentially on these proton density weighted images, it shows up as brighter. So these are the normal open sutures. And so you can see that on all of these cases, we have the parallelogram appearance of the head, but all of the sutures are healthy and open. This is very reassuring. The natural history of the sutures and fontanelles is that at birth they are very wide, and this enables molding as the child passes through the birth canal. And then with progressing age, they would normally narrow, and then they would undergo fibrous closure followed by osseous bridging. That's the normal situation. In contrast, here are a couple cases of premature fusion of the metopic suture with the characteristic trigonocephaly, ectocranial beak, and endocranial notch, indicating early fusion. You can also have hypotelorism and elevation of the medial orbital rims. This is a case of sagittal synostosis. Here we have a dolichocephalic elongated head shape, as well as clear ossification of the sagittal suture, and even some ectocranial ridging or scaphocephaly. Here now are several patients with unilateral coronal synostosis. So you can see this abnormal trapezoidal head shape with premature fusion of the single coronal suture, and then the remaining sutures are patent. On the coronal image, you see that characteristic harlequin eye with elevation of the superlateral orbital rim. And you can even do 3D reconstructions to look at the narrowed and early fusion of that coronal suture. We also have the syndromic synostoses, which tend to involve multiple sutures. On the left, we have a patient with Apert syndrome with the characteristic Turi brachycephaly, or towering and foreshortened skull. And this is a result of synostosis of both coronal sutures, the lambdoid sutures, and even part of the sagittal suture, also known as the midface and skull base hypoplasia. And on the right here, we have a patient with Sather-Choudson syndrome. Unfortunately, it was moving a bit, but you can still see the hyperostotic and synostotic skull, as well as this craniovertebral junction abnormality, which qualifies as anterior homeotic transformation with assimilation of C1. Here's a nice classic achondroplasia case. So we have some frontal bossing, the J-shaped sella, towering petrous apices, foreshortened carotid canals, foramen magnum stenosis, and jugular foramen stenosis. This is a very nice example of one-stop shop MRI in a patient with neurofibromatosis type 1. You have here the classic orbital plexiform neurofibroma, as delineated by the asterisk, with left-sided proptosis and ophthalmos, as well as the remodeling of the bony orbit and sphenoidal dysplasia, giving you the bare orbit appearance, which is really well delineated on the ZTE sequence. Another very nice example of one-stop shop MRI for radiation therapy planning in a patient with masticator space rhabdomyosarcoma, again delineated by this asterisk. You have this expansile mass in the masticator space, and you see that it's causing quite a bit of bone remodeling and thinning, of the pterygoid plate, very nicely demonstrated on the ZTE sequence. ZTE can also be used to evaluate the sinonasal cavity. So here's a patient who had some trouble breathing, and you can see, as delineated by the arrows, that there was bilateral midnasal stenosis. Chronic sinusitis is an interesting application because these patients tend to get several follow-up CTs over the courses of their lives. I do have to provide the caveat that MRI is inherently resolution limited. So for a conventional MRI platform, the best spatial resolution you could get in a reasonable imaging time would be about 1 millimeter or just a little bit better. So therefore, some very thin areas of bone, like in the paranasal sinuses or the temporal bones, can be a little bit hard to see, but nevertheless, you actually get some good suggestion of microstructure and certainly hyperostosis and degree of overall disease is well demonstrated. Dental MRI is actually very common in some countries, for example, Europe, to examine the health of the teeth and also distinguish amalgam and other synthetics from bone. This here is a case of an ameloblastoma, which is being followed in the short term, and certainly there's a bit of resolution limitation, but we can still appreciate the overall bulk of the mandibular lesion, some of the multilocular bubbly septations, and this unerupted molar with some erosions. Also with MRI, you can run other soft tissue sequences to better evaluate the nature of the tumor. This is an unfortunate patient who fell and developed a malignant MCA stroke, which was complicated by a growing fracture or leptomeningeal cyst. So here with the short echo sequence, you can see the very nice demonstration of the separated margins of the fracture with this bulging dura mater from the CSF pulsations and the subjacent encephalomalacia from the stroke. But this is, again, a nice example of bone detail prior to operative intervention. Abusive head trauma is a slightly controversial area for ZTE. Most suspected patients are going to start with a screening CT to look for subdural blood as well as fractures. But then a lot of them end up getting MRI to look for parenchymal injury also. And so if you have a bone MRI sequence, the question is, could you just skip CT altogether? Well, as we've seen previously, there's a spatial resolution limitation. So it's possible that you might miss non-displaced fractures or microfractures. In essence, you have a false negative. However, you could also argue that if you don't have any parenchymal sequelae from those fractures, does it actually matter? At any rate, this particular patient had a CT, did not have any fractures identified, but did have bilateral subdurals, and so MR was ordered. And we can see here that there are bilateral mixed density subdural collections. There's some bridging venous injury. And then on the ZTE, you notice that the sutures are a bit too wide. They're too patulous. And this anterior fontanelle is bulging both on imaging and on examination. So these are indications of acutely increased intracranial pressure. Arachnoid cyst, another possible CSF collection. So ZTE can be helpful either as part of a full MRI or a rapid MRI exam to assess the degree of mass effect on the underlying parenchyma, as well as looking at the deformity of the cranium and making sure that there are no other bony abnormalities prior to any surgical intervention. Many practices will perform both preoperative MRI and CT prior to operative intervention, the CT primarily for bone delineation. And here I'm just showing that there are other ways to accomplish this. This is a patient with post-hemorrhagic hydrocephalus who presented with increasing macrocephaly, and there was some concern, is there anything else going on here? So you do have a pretty nice screen of the parenchyma, certainly no worse than CT. You can also see that the sutures, again, are a little bit patulous, but nothing is synostotic. This unfortunate patient had a high-grade bithalamic glioma. You can see here the infiltrative nature with some internal hemorrhage and necrosis, as well as enhancing soft tissue, causing obstructive hydrocephalus. So after shunting, we performed a rapid MRI, including ZTE, only a few minutes protocol. And now you can see the post-shunt intraventricular pneumocephalus, but also the shunt tip. Essentially, this sequence is the more advanced cousin of gradient echo, so it minimizes susceptibility and air associated with the shunt and gives you a really nice delineation of the tract. This is an interesting case of a patient with chronic epilepsy who was scheduled for surgery, and we did a stealth MRI, including ZTE. So I just thought it was an interesting example of hyperestosis following anticonvulsant therapy. You can see quite a bit of bone stock in the calvarium, pneumosinus dilatans, and so forth. But again, a one-stop shop planning study. So here's some more examples of shunt evaluation. As I mentioned earlier, with the ultra-short echo times, you get really nice delineation of shunt catheter anatomy. And you can also add this on to a rapid MRI exam to look at bone detail. It's very fast. So here, for example, we have plagiocephaly, but the suture is still open beneath the shunt reservoir, still lucent. Here's another example where we have the gyro remodeling seen in very nice detail. This is actually a Schrintzen-Goldberg case, syndromic case, and you can also appreciate here the tribrachycephaly and the platybasia. This is an important example of overshunting. So this patient was chronically shunted, and again, you can see the shunt catheters on both sides. They're chronic subdural hematomas, and they're secondary hyperestosis as well as acquired craniosynostoses. All of the sutures are fused because the brain hasn't been expanding, and so unfortunately this creates an armored brain physiology. In the post-craniotomy setting, ZTE can be a very useful alternative to CT. You actually get very good bone detail of the craniotomy defects, the different tissue properties of air, blood, complex fluid, and even the hardware plated nails with minimal susceptibility. This is a peak or polyether ether ketone cranioplasty, and you can see the dark signal in the areas of the implants, as well as some of the transfixing nails, again with pretty minimal susceptibility, so very comparable to CT. So skull base can be a tricky area for MRI in general, but still ZTE can be really useful as an ancillary tool for evaluating bone stock. Here's a case of chordoma resection with some packing material in the surgical cavity on the traditional sequences, but it's pretty hard to see what bone is left. And here we actually have a pre-contrast and a post-contrast ZTE. You can see that the proton density weighting, because it's such a rapid acquisition, is quite stable between the pre and post exams. You do get a little bit of narrow enhancement and vascular detail, but you can actually perform this sequence either way, and it gives a very nice example of the remaining bone stock at the skull base. Here's a patient who had a zygomatical-maxillary complex fracture, and after the procedure, the surgeon really did not want to re-irradiate the patient, but wanted to check that the anatomic fragments were in appropriate alignment. So we did this zero echo time sequence, and you can see that it's very nice. All of the fragments are there. You can see the fixation plates with pretty minimal susceptibility. So again, a fair complement to CT. Here's a patient with more complex craniofacial trauma who had multiple left calvarial fractures, as well as bilateral Lefort-2 fractures. So again, with MRI, you're a little resolution limited in areas of really thin bone, particularly the paranasal sinuses, but we still get a really good assessment on follow-up of the defects in the anterior skull base, in the orbit, and also the hardware reconstruction of the calvarial fragments with minimal susceptibility. To conclude from our clinical cases, major pitfalls for interpretation are going to be MRI artifacts. So even though ZTE is pretty artifact resistant, it still takes a couple minutes, and if the patient's really on the move during that time, the results can be pretty ugly. Here, though, is the same patient after feed and swaddle and being held by the tach, so you can see the results are a lot better. And remember, For infants, you don't have to have perfect imaging, but just being able to assess head shape and interrogate the sutures of interest is still really helpful. Here's another patient with dental hardware where we see some blooming artifact that obscures the paranasal sinuses. Another caveat is going to be areas of thin bone or low ossification. So younger patients or tough areas like the sinuses, the skull base, and temporal bones. False negatives could be microfractures or non-displaced fractures, particularly less than 1 millimeter resolution. False positives could include nutrient foramina, these little vessels coursing through the bone like so, but typically you can scroll back and forth, and with your knowledge of anatomy and know that these are serpiginous, you can figure it out. Final pitfall is any interface. So bone-air interfaces, both of them are going to be low signal and difficult to measure, so that can be really hard to distinguish. Also, any soft tissue interfaces like the fat-water interface with the fascia becomes very dark and can be difficult to distinguish from bone. And then variable intensity secretions in the sinuses and mastoids. Finally, validation. Does this have value? So we have a large-scale research study going on right now, funded by multiple foundations, including the ASHNR, to look at the diagnostic efficacy of ZTE versus CT for clinical applications. So we're looking at multiple things. One thing we're doing is having radiologists score the landmark visibility as well as their diagnostic confidence for various areas of the head and neck. So we're looking at different parts of the calvarium, sutures and fontanelles, the skull base and temporal bones, as well as the face, paranasal sinuses, jaws, and teeth. In terms of enhancing current technology, we can first look at improving our hardware and software acquisition. Using ultra-high field and gradient modulated techniques, our collaborators have been able to image the inner ear with high fidelity and generate reconstructions of the bony labyrinth. Now, although susceptibility effects are usually exaggerated at higher fields, the use of an ultra-short echo technique essentially negates the dephasing properties, enabling you to capture cortical bone with high fidelity. Now, another comment I get is about accessibility. So people will say to me, maybe this works, but still, CT is easy, it's cheap, I know how to read it. Why do I need to learn how to read something new? And so we're working very hard on generating synthetic CT images, which people will be comfortable with, both radiologists and surgeons, in their daily work. Now, there's a conventional medical image processing technique to this. You can take the conventional magnitude black bone image, and you can do a logarithmic inversion. So now you get a bright bone image, but of course the air is also bright along with the bone. So then you can do histogram subtraction to mask out the intensity of air, which is slightly different. However, you see that you will also lose some microstructural detail, particularly the mastoid septae. Still, it looks pretty good. And from this, you can generate 3D multiplanar reformats. So these actually look quite decent. You have the bones of the skull and face. You also see some intracranial structures, so pretty comparable to CT. You could even do 3D reformats, which look pretty nice. So most people would not believe that this came from an MRI. They would think it had to be a CT, but no. The only problem is that the assumptions we make in conventional image processing don't always hold for patients with pathology or younger patients. In particular, these patients may have thinner and less ossified bone, less well-developed soft tissues, and then variable secretions in the sinuses and the mastoids. So this presents a great opportunity for deep learning, because convolutional neural networks allow us to perform nonlinear mappings from MRI to CT images. They also enable the algorithm to learn from anatomic context, and we can provide diverse training data with various MRI techniques. We can also engage transfer learning, utilizing information learned from other similar data sets to solve difficult problems, including bone masking, edge detection, Hansfield unit prediction, as well as image enhancement like denoising and super resolution. Here's some of our preliminary work in the deep learning space. Actually, this algorithm is based off only a third of our current total data set. But still, I wanted to include the preliminary examples to show you the promise of synthetic CT in deep learning. You can see that these problem areas I mentioned before, the thin bone in the orbits, the paranasal sinuses, the skull base and temporal bones, you're actually detecting some microstructure, some of these very thin septae that are actually limited and would not be detectable either by conventional image processing or the inherent limitations of the MRI technique. We are also doing a lot of 3D modeling for surgical planning, and the results, particularly for the cranium and jaw, are really exciting. So we're achieving surgical precision with less than 2 millimeter deviation between ZTE and CT in all of our cases. Here I'm showing several patients' heat maps, which are colorized such that a deviation of 0 would be centered around green, and then plus or minus 2 millimeters are going to be red or blue, respectively. So excepting a few areas of noise or artifact, the results are really good. Now, in the face and the skull base, we have some segmentation challenges because it's just very hard to manually segment thin bone and complex anatomy in these regions. So when we co-register the two modalities, it does look like they correspond, but currently with the MRI intensity differences, it's just very hard to actually run that through a 3D printing process. So we hope that the synthetic CT deep learning approach will help us to better automate the 3D visualization. Because ZTE is not yet standard of care, we cannot perform actual patient surgeries based on the technique. However, our surgical collaborators have performed mock craniotomies and fibular free flaps on cadavers, and were able to show that virtual surgical plans based off each modality did not differ significantly in the postoperative deviation from the plan, and both were well within surgical precision limits of 2 millimeters. So going back to the title of the talk, can this replace CT? Well, I think it depends on your outlook. Are you a glass half full or half empty type person? And there's a whole spectrum of potential responses. Now, I've worked a lot with technology, and I know MRI is always improving, so I tend towards the probability answer. But I bet for anyone watching this talk, very few would have suspected that this particular 3D image on the right came from a MRI rather than a CT. So for the skeptics among us, I would say, in the words of Justin Bieber, never say never. Thank you so very much for your attention. Please feel free to email me with any comments, ideas, or suggestions. I'm also trying to get more information, disseminate education about this technology, and also open to any research collaborations.
Our next speaker is Dr. Kristen Bognon. She is an associate professor at the Department of Radiology and Imaging Sciences in the Division of Neuroradiology at Emory University in Atlanta, Georgia. And her topic is cysternography, CT versus MRI.
Good morning. First, I'd like to thank Dr. Schmalfus and the program committee for the invitation to speak to you today about cysternography, CT versus MRI. I have nothing to disclose. So by the end of our talk today, you should be able to determine the optimal imaging modality to work up your patients with suspected skull-base CSF leaks. We're going to review some techniques on how to optimize cysternography imaging protocols and provide you with some tips and tricks for interpreting these exams. Finally, we're going to review some interesting cases highlighting pearls and pitfalls in the interpretation of CSF leak imaging. So first, remember, skull-base CSF leak is defined as the egress of CSF from the subarachnoid space into either the nasal or middle ear cavity, presenting with rhinorrhea and or otorrhea, and its presence requires both an osseous and a dural defect. It's imperative to diagnose and treat a CSF leak, as untreated CSF leak can lead to meningitis in up to 50% of cases, as in this case of a patient with a recent history of facial trauma who presented with altered mental status and an awful meningitis with flare signal abnormality in the sulci, ventriculitis with debris layering dependently in the ventricles, and posterior circulation vasculitis leading to infarctions. All due to this undetected right sphenoid wing fracture that occurred at the time of his facial trauma 1 week previously. So historically, the most frequently encountered types of CSF leaks are traumatic leaks, those that result from accidental trauma, as in the prior patient, or iatrogenic trauma due to skull base or endoscopic sinus surgery. Rarely, leaks can also occur due to underlying congenital lesion or tumor. However, we're increasingly seeing patients with spontaneous CSF leaks without any history of trauma or known etiology, and these patients often have clinical and imaging overlap with idiopathic intracranial hypertension, or IIH. So just to spend a minute on spontaneous leaks, as these are the types of leaks that we're seeing the most frequently. Again, these are leaks that occur in patients without discernible cause, and often, but not always, there's overlap in the clinical presentation and imaging finding of patients with IIH, as they're often seen in obese middle-aged females with a BMI over 30, and occurs in a female preponderance of anywhere from 4 to 15 times more frequently than males. Remember, IIH is the presence of elevated CSF pressure with normal composition and no definite underlying cause. However, patients' pressures may be normal or only mildly elevated in the setting of a resultant CSF leak. The incidence of IIH is increasing as the BMI continues to increase throughout the U.S. In 2018, based on the national survey data, adult obesity rates exceeded 30% in 31 states and 35% in 9 states. You can see that at Emory University in Atlanta, Georgia, I work in the heart of the Southeast Biscuit Belt, as I like to say, so we do see a fair amount of IIH. So there are some characteristic imaging features of IIH that we can see and identify in our cisternogram and imaging workup of CSF leak patients. And it's important to recognize and report these, as these patients are historically more challenging to deal with, as they may recur more readily or spring another site of leak after one site is repaired. Identifying the possibility of underlying IIH may alter the management of these patients, as the surgeons may be more aggressive about treating them with Diamox or lumbar drain perioperatively. So before going into the details of cysternography, I want to briefly review the characteristic imaging features of underlying IIH that we may see and we should report in these spontaneous CSF leak patients. So first is the so-called empty sella, with bony enlargement of the sella and herniation of the subarachnoid space into the sella, flattening the pituitary gland. This is the most common IIH finding, but it can also be seen incidentally, so you need to take into account other clinical and imaging features, particularly the patient's age. Of note that empty sella appearance can improve after treatment. In IIH patients, you can often see scalloping of the skull base and lobulated, prominent T2 hyperintense arachnoid pits and granulations, often seen along the anterior middle cranial fossa and sphenoid wing. Multiple skull-base osseous dural defects are extremely common, if not almost entirely seen in these patients, often associated with meningoencephalous seals. In this patient, for instance, with a BMI of 56, you can see multiple skull-base defects. The first is one of the most classic sites of osseous defects in these patients, the inferolateral or pterygoid recess of the sphenoid sinus. But also you can see meningoencephalous seals along the already thinned cribriform plates and lateral lamella. And these are often subject to dehiscence, as is the case bilaterally in the same patient. Ethmoid roofs are also common sites of defects, with or without meningoencephalous seals. In this patient on coronal T2-weighted MR, you can see inferior herniation of mildly gliotic brain and CSF extending inferiorly through a defect in the right ethmoid roof compatible with meningoencephalous seal. Finally, the tegment is another common site of osseous dural defects in these patients. And this is an example of bony tegment defect on CT with adjacent soft tissue in the mastoid air cells with complete opacification of the right mastoid. MRI best demonstrates the findings of associated meningoencephalous seal, as you can see the vertical orientation of the adjacent CSF cleft, along with inferior tethering and traction gliosis of the adjacent inferior temporal lobe parenchyma. Petrous apex cephalous seals are also extremely common, especially along Meckel's cave, as are meningoseals in the region of the geniculate ganglion of the facial nerve, and enlargement of the skull base foramina, as in these prominent foramina ovale. Low-lying cerebellar tonsils can be seen and mimic Chiari malformations, and the key is to look at the sella in any patient with low-lying tonsils. If it's expanded and empty, one should suggest the possibility of IIH and look for other signs. However, remember that this finding is typically only seen in patients that are currently experiencing elevated pressures, which is often not in patients who are actively leaking. Stenosis of the distal transverse and sigmoid sinuses, as in this patient, is often seen, and it's unclear whether it's a cause or a result of IIH, sort of a chicken and the egg phenomenon, but you can see improvement of this finding after normalization of the ICP. And finally, the orbital findings associated with IIH, including flattening of the posterior globe and optic nerve head protrusion, optic nerve sheath enlargement and tortuosity, as well as occasional enhancement of the optic nerve head, are all associated with papilledema, which is actually rare when the patient is actively leaking, again, as their pressure may be close to normal at that time. So how do patients present to lead the referring physician to suspect a CSF leak? Well, the classical clinical presentation is that of clear watery rhinorrhea, which worsens with Valsalva and the head down position. While we typically think of rhinorrhea as due to a sinonasal skull-base defect, remember that Tegman defects can also present in this manner due to egress of CSF through the eustachian tube. Tegman defects often also present with Sinusitis media, which can bubble with bubbles that can increase with Valsalva, and can rarely present with otorrhea if there's a tympanostomy tube or a TM perforation. Patients can present with meningitis. In fact, patients with recurrent meningitis should necessitate a CSF leak workup. Pneumocephalus can also be seen, most often post-traumatic or in the postoperative setting. And rarely it has been reported that patients can have symptoms of intracranial hypotension. However, this is typically only in very active leaks with significant rhinorrhea. Low-pressure headaches are much more often seen with spinal leaks, so much so that in the setting of low-pressure headache alone, one should not start with cysternography in the workup of these patients, but consider spinal MRI or myelography. However, any of these clinical presentations, particularly with the added history of prior trauma, skull-base or endoscopic sinus surgery, tumor, or obesity, should necessitate workup for a CSF leak. So the first step in the workup of suspected CSF leak prior to any imaging is a screening test that's become the gold standard method to obtain a clinical diagnosis is a beta-2 transferrin assay of the rhinorrhea. Beta-2 transferrin, or the newer beta-trace protein, are proteins specific to the CSF. They shouldn't be found in the serum or elsewhere, and has a very high sensitivity and specificity with unequivocal evidence to support its use. The patient collects the rhinorrhea into a small test tube by leaning forward. It only takes a few drops, and they can store it at room temperature or in the refrigerator. Kind of keep the test tube handy with them and pull it out whenever they feel the rhinorrhea coming on. The limitations, of course, are in those patients with intermittent or no leak who are unable to obtain fluid, and very rarely you can see false positives in the settings of liver failure. Finally, the imaging evaluation. So what are the goals of imaging a patient with suspected CSF leak? Well, imaging is paramount as the majority of repairs performed now are endoscopic, and the main goal of imaging is to localize the leak and characterize the size of the defect for preoperative planning. Of course, it's nice to confirm the diagnosis, especially in those patients with suspected leak but unable to obtain fluid for beta-2 transferrin testing, and to assess for an underlying cause such as IIH or underlying tumor or associated meningocele. There are many different imaging modalities and cysternography techniques for assessing CSF leaks, and the fact that there is no definite imaging gold standard just highlights the fact that this is often a difficult diagnosis to make. There are no randomized controlled trials, but I'm going to review the different imaging modalities and present an algorithm based on our institutional experience and the available literature. So prior to considering any sort of cysternography, the initial imaging study of choice, which is unequivocally supported by the literature and should be the standard of care, is a thin section high-resolution CT through the sinuses, using sub-millimeter images and making sure to extend all the way through the mastoids. This is the most sensitive method for identifying an osseous defect and will be used for surgical planning. The beauty of this modality is that we don't need an active leak to identify an osseous defect along the skull base. On CT, it's important to look for any polypoid non-dependent soft tissue next to an osseous defect, especially if it's in the olfactory recess, as in this case, and in that setting, you want to consider an MRI to assess for a meningoencephalocele. So on CT, it's really important to look for the site of osseous defect in multiple planes, optimizing the window and leveling. For instance, here's a case of a patient with a remote history of trauma with a subtle linear lucency through the right ethmoid roof in the axial plane, which is unequivocally the site of leak when seen on sagittal and coronal reconstructions. If there's only one osseous defect in a patient with a definite leak and positive beta-2 transferrin, then no further imaging is necessary and the patient may proceed on to surgical repair. However, here's a bit more complicated case. This is the 48-year-old obese male with a BMI of 56 that we showed earlier, who had definite CSF rhinorrhea with a positive beta-2 transferrin. Unfortunately, he had multiple defects with adjacent non-dependent polypoid soft tissue within the left sphenoid sinus, along the right ethmoid roof, and along the tegmen bilaterally, worrisome for multiple cephaloceles, all compatible with underlying IIH. In the setting of beta-2 transferrin and multiple defects and potential sites of leak, it can be difficult to decide which is actively leaking and needs to be addressed first. Therefore, this is a patient that will then require cysternography. So CT cysternography can be a useful tool to attempt to elucidate which is the site of a leak in a patient who is actively leaking. The technique involves first performing a non-contrast routine thin section CT through the sinuses and mastoids in the supine position with soft tissue coronal and sagittal reformations. The patient is then taken to the fluorosuite where 7 to 10 cc's of myelographic intrathecal contrast is instilled via lumbar puncture, and the table is tilted to move the contrast to the basilar cisterns. Then the patient is brought back to CT, and just prior to scanning, the patient should roll around completely 360 degrees on the table and then perform a prone head-hanging maneuver for a minute off the edge of the scanner in an attempt to provoke a leak. Next, the patient is initially scanned in that prone position in an effort to elicit a leak. And then finally, the patient's rolled back to the supine position, rescanned in their initial position, the same as the initial scan, with soft tissue coronal and sagittal reformations performed so that the pre and post contrast images can be compared side by side, apples to apples. So positive findings on a CT cysternogram include a bony defect with adjacent increase in density of soft tissue within the sinus or mastoid adjacent to the bony defect, particularly if there's pooling of high density in the adjacent sinuses, as in this case, of a probable meningoencephalocele in the left sphenoid sinus with adjacent leak and pooling of contrast in that sphenoid sinus. In another patient, a pre-contrast CT shows a focal osseous dehiscence of the left cribriform plate and lateral lamella with adjacent polypoid soft tissue that increases in density on the post-contrast imaging. In addition to seeing a visible increase in attenuation, a 2 times or greater increase in density by measuring Hounsfield units can also be suggestive of a leak. However, it's important to remember that the patient must be actively leaking for the study to be helpful and positive, so it's only indicated in patients who are able to test for beta-2 transferrin and able to elicit a leak. Direct prone coronal images can be really helpful, as in this case where you can see extension of contrast through a defect in the right cribriform plate with filling of the adjacent ethmoid sinuses. You can note the souffle effect with increased density of contrast dependently, and a slight relative washout of contrast at the skull base on the right compared to the left due to the active leak. Additionally, in the image on the right, which is several slices anterior to the image on the left, there is dependent drainage of contrast into the right nasal cavity, confirming a leak, keeping in mind the patient's prone position on these images. So one can often see movement of the high-density fluid in position from the prone to the supine images, which can help to confirm the free leakage of contrast. Here's an example of a challenging CT cysternogram case. This is a patient with a prior left frontal cephalocele repair with persistent rhinorrhea. You can still see the large defect at the site of the surgical repair, which may or may not be granulation tissue, as well as a tiny defect adjacent to a partially opacified right supraorbital ethmoid cell. The patient also had bilateral tegmen defects with adjacent soft tissue and fluid in the right mastoid air cells, as well as findings suggestive of IIH with prominent sphenoid wing arachnoid granulations. So this case demonstrates some of the challenges of CT cysternogram. So first, evaluating a prior surgical bed with a rim of increased attenuation around the bed can be challenging. It's really important to compare the pre and post images side by side to exclude the underlying scar tissue and osteoneogenesis. Also, when encountering tegmen defects and soft tissue in the mastoids, detecting an active leak in the mastoids can be really difficult, and it can be challenging to avoid air cell septations when drawing ROIs. I found it really helpful to compare the pre and post contrast images carefully side by side on the same algorithm images, and to closely evaluate for any change between the prone and supine images to look for layering high-density fluid. So in this particular patient, once comparing the images carefully side by side, one can appreciate the filling of a right supraorbital ethmoid cell in the post-contrast images, which was determined to be the site of the leak in this patient. So MRI cysternography is a really good technique to use in instances where there's polypoid non-dependent soft tissue on CT adjacent to a bony defect, as it can help to identify contents of a meningoencephalocele. It's most sensitive and specific when you interpret the MRI side by side with CT. One should look for CSF signal extending from the subarachnoid to the extracranial space at the site of the bony dehiscence to suggest the site of a CSF leak. The beauty of this technique is you don't have to be actively leaking at the time of the exam, and of course it's non-invasive and non-ionizing. The highest yield sequences for trying to detect a site of leak on MRI cysternography is very thin section, heavily T2 weighted sequences obtained in the coronal plane, preferably with sub-millimeter isotropic images able to be reformatted into other planes. These include 3D FSE space sequences, or balanced steady-state gradient echo sequences such as the KISS or Fiesta sequences. We also perform pre- and post-contrast thin-section T1 weighted images to look for dural enhancement. So to summarize our suggested imaging algorithm workup for the workup of a suspected CSF leak, all workups should start with beta-2 transferrin testing. If beta-2 transferrin is negative, then no imaging is necessary, as it's unlikely to be a CSF leak. If beta-2 transferrin is positive, then imaging should start with a thin section CT of the sinuses extending through the mastoids. If there's a single osseous defect, that's the most likely site of the leak, and no further imaging is necessary. The patient can go on to surgical repair. If polypoid soft tissue is seen next to a bony defect, one should suspect a meningoencephalocele and consider MRI cysternogram to evaluate the extent of the encephalocele. If there's a positive beta-2 transferrin and multiple osseous defects are seen on CT, then the patient has a provocable leak. That's the indication for CT cysternogram to attempt to elucidate which site is leaking. And finally, if the patient is unable to collect fluid, however, the team is highly suspicious of a leak, one should start with a CT, but then also consider MRI cysternogram to assess for a possible site of leak and to assess any areas of abnormality on that CT. CT cysternogram would likely not be helpful in that setting because the patient is not actively leaking. So now I'm going to work through that algorithm with some cases and highlight some pearls and pitfalls with real-life examples. So the first case is a 45-year-old female with an elevated BMI who presents with left-sided clear rhinorrhea. So to start, what would you do first? Well, first we said in our algorithm is you want to test the fluid for beta-2 transferrin, and it's positive. So then what would we do next? Well, we should start with a thin section CT through the sinuses, which in this case showed multiple defects along the cribriform plate bilaterally, along with serpiginous lucencies that extended along the base of the crista galli and roof of the nasal septum bilaterally with adjacent polypoid soft tissue in the olfactory recess, along with some features of underlying IIH with scalloping of the less sphenoid wing and an expanded empty sella. So what would we do next? Well, we recommended an MRI cysternogram due to the polypoid soft tissue and suspected meningocele. And in this case, again, you can see bilateral linear tracking meningoceles along the base of the crista galli and superior nasal septum. So that was an example of an entity known as an excavating meningocele, which is a type of meningocele we can see in IIH in which there is excavation of the skull base in a tunnel-like fashion, often but not always taking the path of least resistance through the olfactory neuroforamina. The linear and seemingly multifocal nature of these defects make them difficult to recognize, and you often need both a CT, non-contrast, and MRI cysternogram for surgical planning. It's really important to describe and measure the entirety of these defects, as they can be associated with a high rate of recurrence if they're not addressed in total. Case 2 is a 43-year-old female with elevated BMI who presents with headache and right ear fullness. So what would we do first? Well, we're going to start with beta-2 transferrin. If it's positive, of course, the first thing we're going to do is a CT. And in this case, you can see scalloping. Well, actually, the image is not shown. There was significant scalloping of the skull base and a prominent empty sella compatible with IIH, as well as multiple lucencies along the right tegmen with patchy right mastoid opacification. At that time, no definite additional sites of leak were identified. So what would we do next? Well, we have one potential site of leak, so the patient should go for surgical repair, which is what happened. They went for right mastoidectomy and middle cranial fossa approach for repair of the tegmen. However, 6 months post-operative, the patient was continuing to leak, again, positive for beta-2 transferrin. So because we have a provocable leak in the setting of a surgical bed and potential additional sites of leak, we recommended a CT cisternogram. And here on the postoperative CT cisternogram, you see the postoperative changes from the mastoidectomy with fat packing. But you can also see CSF filling the right petrous apex meningocele, which in retrospect was present on the preoperative CT and MRI, unfortunately. So the potential pitfall in this case is that petrous ridge meningoceles can easily be overlooked if they're not looked for. Okay, case 3, our final case, is a 68-year-old female who presents with recurrent meningitis, and she had intermittent rhinorrhea by history and bilateral middle ear effusions on exam. So what would we do first? Well, they attempted to collect fluid with beta-2 transferrin, but the patient wasn't draining enough. But the team had a very high suspicion for intermittent leaks. So what are we going to do next? Well, again, always start with CT. And in this case, we saw large defects along the bilateral tegmen, tympani, and mastoidium with opacification of the middle ear mastoids bilaterally. So again, we have recurrent meningitis, high suspicion for a leak, but unable to test with beta-2 transferrin, multiple osseous defects with adjacent opacity. So in this setting, we recommend MR cisternogram. And in this case, we saw on the right a vertically oriented sulcal cleft and gliosis of the adjacent temporal lobe cortex, compatible with a right tegmen meningoencephalocele. And on the left, the brain parenchyma remained intracranial adjacent to the osseous defect. However, there was T2 hyperintense CSF signal extending inferiorly, suggestive of a meningocele in this case as well. So in this patient, they were thought to have bilateral tegmen tympani and mastoidium CSF leaks. However, also had meningoencephalocele on the right, so it was a little bigger on the right. So the patient underwent a staged repair addressing the right side first. And one of the other pearls is just it's really important to report dimensions of the defects in multiple planes bilaterally so the surgeon can plan the size of the dural repair. So in conclusion, approach to the patient with a CSF leak, of course, always start with a beta-2 transferrin analysis and CT. If there are multiple defects in an active leak with positive beta-2 transferrin, then those are going to be the candidates for CT cisternogram. MRI is helpful in patients with suspected meningocele or in patients with high suspicion but unable to test for beta-2 transferrin. Always look for signs of IIH on any patient with suspected CSF leak, and if you see them, look for multiple sites of leak, including the excavating meningoceles. And don't ignore the thin, irregular cribriform plate and olfactory recess. If you see an opacified air cell superiorly or soft tissue in the olfactory recess, look for an adjacent bony defect and can recommend correlation with any CSF leak symptoms. And if they exist, consider beta-2 transferrin and MRI for further evaluation. So I want to thank you so much for your time and attention. I really miss seeing all of you in person in Orlando this year. And I want to congratulate Dr. Schmalfuss on an outstanding virtual meeting. I really look forward to hopefully seeing you all again next year. Thanks so much.
The last speaker in this session will be Dr. Reza Forghani, who is an associate professor in the Department of Radiology and the director of Augmented Intelligence and Precision Health Laboratory at McGill University in Montreal, Quebec. And his topic is Dual Energy CT, Principles and Head Neck Applications.
Good morning. Today I'll be speaking to you about dual energy CT applications for head and neck imaging. These are my disclosures. This is a broad outline of this talk. I will begin by briefly discussing fundamentals of DECT, including for material characterization. This will be followed by a review of different head and neck applications of dual energy CT. The talk will conclude with a brief discussion of emerging applications and future horizons for this technology. Let's begin by briefly discussing dual energy CT or DCT. With conventional single energy CT scans, a polychromatic X-ray beam is emitted by the tube. Attenuation data are captured by the detector array, and these are used to reconstruct CT images you're all familiar with. With DECT, instead of using attenuation data acquired at one energy spectra, attenuation data are acquired at two different energy spectra. This enables the generation of different reconstructions and material characterization beyond what is possible with conventional single-energy CT scan technology. There's not enough time in this talk to discuss in detail different DCT scan acquisition approaches and clinical scanners, but you should become familiar with the type of scanner you have in order to effectively implement clinical DCT protocols. I do, however, want to briefly discuss DCT material or tissue characterizations, since this is fundamental for DCT applications for head and neck imaging. Without getting into a detailed discussion of CT physics, CT attenuation is largely due to Compton scatter. A smaller part of CT attenuation is due to photoelectric effect, but this is particularly important for DCT. Rayleigh scatter, typically accounting for less than 5% of attenuation, is usually considered negligible. It is important to understand that the photoelectric effect depends on the atomic number of an element. Elements with higher atomic numbers have a greater degree of photoelectric effect. And this is important for DCT applications. To give you an example, elements of common soft tissues, such as hydrogen, oxygen, carbon, and nitrogen, have very low atomic numbers. It would not be realistic to try to discriminate tissues mainly composed of such low atomic number elements using dual NGCT technology. Elements with high atomic numbers, on the other hand, have strong spectral properties that can be exploited to perform a number of different characterizations using dual NGCT. Examples are calcium with an atomic number of 20 and iodine with an atomic number of 53. In this slide, I would like to demonstrate some of the principles we just discussed. On the left, I'm showing an unenhanced acquisition through the neck with region of interest analysis. If you look at the green ROIs, these are placed on uninfused muscle. As you will see on the spectral Hounsfield unit attenuation curve shown on the right, there's essentially no significant change in attenuation of the muscle on the scan at different energies. This is because the main attenuation here is through Compton scatter, related to the low atomic number of constituent elements. On the other hand, ROI analysis of thyroid gland, which contains iodine, demonstrates significant changes in attenuation at different energies because of strong spectral properties of iodine. This is exploited for different head and neck imaging applications, as you will see shortly. The last physical principle that is important to understand DCT applications is the concept of KH. At an incident photon energy just above the KH, there is an abrupt increase in photoelectric interactions and consequently attenuation. This is followed by progressive reduction in attenuation with increasing energy above the KH. This principle explains the characteristics seen on the curve here on the ROI analysis of the thyroid gland. Iodine has a KH of 33.2 kiloelectron volts. Therefore, at lower energies approaching iodine's KH, there is significantly increased attenuation, as you can see on this image. As a reference, a typical single energy CT would be considered equivalent to attenuations you're seeing at 65 or 70 kiloelectron volts. The use of Hounsfield unit attenuation curves and differences in these curves for different tissues was demonstrated in some of the early attempted applications of DECT for head and neck imaging. This is a figure shown by a study done by my colleagues at Michigan in 2013, demonstrating different spectral Hounsfield unit attenuation curves of head and neck cancer malignant tumors compared to normal tissues. Now, before we proceed to specific applications of DCT for head and neck imaging, I want to briefly discuss the different and common reconstructions generated using DCT. One type of reconstruction you need to be familiar with is the virtual monochromatic images, henceforth referred to as VMIs. These are also referred to as virtual monoenergetic images. VMIs essentially represent reconstructions that are generated using sophisticated computerized algorithms using the low and high energy data acquired with DCT. These simulate what a scan would look like at a given predicted or prescribed energy as if it was acquired with a monochromatic beam at that energy. In this slide, I'm showing you some examples of VMIs reconstructed from the same DECT acquisition. This is a contrast-enhanced neck scan of a patient with a left tongue cancer. Reconstructions are made at low energies down to 40 kV all the way to 140 kV. As is clearly evident on the images, the tumor's attenuation is highest on the low energy 40 kV VMIs. This progressively decreases with increasing VMI energy, a qualitative correlate for what I showed you earlier using the spectral Hounsfield unit attenuation curve. At the highest energy, which is 140 kV, the scan essentially starts to resemble a virtual unenhanced neck CT. Based on extrapolation from abdominal imaging phantoms as well as studies we performed on head and neck, a 65 or 70 kV VMI is typically considered the equivalent for a standard 120 kVp single NGCT acquisition. If you have a fast kVp switching scanner, you want to reconstruct one of these energies as your standard reconstruction. Now, the other main type of reconstruction to be aware of is the weighted average image if you're using a dual source DCT scanner. A linear blending of 30% of low energy acquisition and 70% of high energy acquisition is typically considered equivalent to a standard single energy CT. Somewhat similar to the principle of different energy VMIs, alterations in blending for weighted average images can be used to enhance different characteristics of interest on these images. Now, the last type of reconstruction I want to discuss before we proceed to specific applications is the basis material decomposition map. This is a type of reconstruction you're not used to seeing with conventional single energy CT scans. Material decomposition maps can be used to demonstrate the distribution and relative content or concentration of certain elements within tissues. In this example, a laryngeal cancer is shown. As you can see on the image, there's higher iodine content within the tumor compared to normal soft tissues such as muscles. Material decomposition maps are an important and powerful application for dual energy CT. However, they're not without limitation. One pitfall one needs to be aware of is the high signal of calcium-containing tissues such as bone on these images, as shown here. Because of overlap in physical properties of calcium and iodine, a complete separation of the two is not possible using basis material decomposition. For this reason, calcified tissue will have high signal on iodine maps. This should not be confused with high iodine signal. This pitfall needs to be kept in mind when interpreting these reconstructions. Let's now proceed to a review of different head and neck applications of DCT. Perhaps the largest body of evidence and investigations for DCT applications in the head and neck pertain to evaluation of head and neck cancer, and specifically head and neck squamous cell carcinoma. Now, we discussed that 65 or 70 kV VMIs have the best SNR. However, does that mean that they're the best reconstructions for assessment of tumor? We have already discussed how lower energy VMIs can be used to increase enhancing tumor conspicuity. Different studies, including from our lab using different scanners, have demonstrated that tumor attenuation increases on lower energy kV VMIs and is highest on the 40 kV VMI. Now, when one thinks of soft tissue contrast, it is not only a question of absolute attenuation. Therefore, in one of our studies, we also evaluated tumor attenuation and compared it to that of muscle, and we still found the greatest separation on 40 kV VMIs. This was further confirmed by formally measuring contrast to noise ratio, either in tumor tissue or in pathologic lymph nodes, essentially demonstrating the application of low energy VMIs for increasing tumor visibility and soft tissue boundary delineation. Now, I need to mention that when it comes to contrast to noise ratio, and even more so to subjective evaluation of different energy VMIs, there is not consensus in the literature on which low energy VMI is optimal, and some studies favor a slightly higher energy. A detailed discussion of this is beyond the scope of this talk, but it should be noted that many of these studies were in the earlier days of DECT, and at least as it pertains to CNR, certain mitigation strategies are possible for noise reduction that would make it such that the CNR would be highest on 40 kV VMIs. Now, we discussed quantitatively this application. Let's look at some images. This is 65 kV VMI, what would be considered similar to a conventional single energy CT scan of a patient with a floor of mouth cancer. The image on the right is the 40 kV VMI. I believe everybody would agree that the tumor, as well as its soft tissue boundary, is better seen on the 40 kV VMI. This is another example of 65 kV VMIs of a small laryngeal cancer extending to the anterior commissure. The lower panel demonstrates the 40 kV VMIs from the same acquisition, again where the tumor is much better seen. In this case, a 65 kV VMI is shown from a patient with a superficial and subtle oral tongue cancer. Can you see the lesion? Here is the 40 kV VMI. Note how the small right oral tongue cancer is better seen on the 40 kV VMI. Lastly, this is an example of a patient with a small buccal mucosal cancer. Here's the 40 kV VMI, where again the superficial tumor is better seen compared to the 65 kV VMI. Now, I alluded to subjective acceptance of low energy VMIs, which was especially an issue with the earlier versions of dual energy CT scanners. We actually performed a study formally evaluating this, consisting of multiple radiologist evaluations that included head and neck imaging experts as well as general radiologists. If the specific question was posed, which VMI energy is best for tumor assessment, 40 kV by far did the best. However, as you can see in the graph on the right, if the question was more generic, pertaining to aesthetic appearance of the image, the 60 and 65 kV VMIs were clearly preferred. Now, we discussed the higher noise on low energy VMIs. There are mitigation strategies for this. This is one example of a mitigation strategy by our colleagues in Germany using what is referred to as a monoplus reconstruction from a dual source, dual energy CT scanner. Using this noise reduction technique, the CNR was indeed highest at the lower energies. This is an example of application of monoplus low energy VMIs. On the left, you have the reconstruction that is not monoplus, and on the right is the application of monoplus, and as clearly seen here, the image is much less noisy. If one has a fast KVP switching scanner, one approach for reducing noise is selecting the best and right Acer setting. Now, the discussion has largely been on application of VMIs for improving tumor visibility and soft tissue boundary delineation, but as sort of alluded to earlier, changing the blending of weighted average images from those source scanners is also a strategy that has been shown to enable improving tumor visibility. When it comes to application of low-energy VMIs, not only are they useful for evaluation of primary tumor, they have also been shown to be useful for evaluation of tumor recurrence. This also includes a study from our colleagues in Michigan that formally evaluated tumor recurrence that demonstrate that 40 kV VMIs, in addition to iodine concentration on iodine maps, could be used to improve discrimination of tumor recurrence from post-treatment changes and non-tumoral tissues. In this image, I'm showing you an example of the application. The left panel demonstrates a 65 kV VMI. The middle panel is showing you the 40 kV VMI, which I believe better demonstrates the difference between the recurrent tumor more anteriorly and the post-treatment changes more posteriorly. The right panel demonstrates the iodine map that also shows this distinction very well. Now, in addition to applications for improving tumor visibility, dual NGCT has also been shown to be useful for discrimination of thyroid cartilage invasion from non-ossified thyroid cartilage. The challenge with evaluation of thyroid cartilage is that it ossifies in an unpredictable manner. Furthermore, non-ossified thyroid cartilage has an attenuation that can be similar to enhancing tumor on a contrast-enhanced CT scan. As such, there can be challenges in interpretation when a tumor abuts the non-ossified thyroid cartilage. In one of our early studies, we demonstrated that non-ossified thyroid cartilage has a different spectral 100 unit attenuation curve when compared to tumor. More specifically, as discussed earlier, with increasing VMI energy, the iodine attenuation within enhancing tumor is suppressed. On the other hand, the avascular cartilage has relative preservation of its high attenuation. This enables discrimination of non-ossified thyroid cartilage from tumor on high-energy VMIs. I showed you some graphs, but let's look at an image. In part A of this figure, a 65 kV VMI is shown. There is a large suprapulodic mass abutting the non-ossified thyroid cartilage. I think everybody would agree that it is not possible to clearly distinguish the boundary between tumor and the non-ossified thyroid cartilage. Now the middle panel demonstrates a 40 kV VMI. This somewhat improves the discrimination, but this effect is not consistent. On the other hand, if one looks at the high-energy 140 kV VMI reconstruction, note how there is clear suppression of iodine with an enhancing tumor, but preservation of high attenuation of non-ossified thyroid cartilage, enabling clear discrimination of the boundary between the two and confirming non-invasion of thyroid cartilage in this case. Iodine maps have also been demonstrated to be useful for determination of thyroid cartilage invasion, as shown in this study in 2012. Furthermore, in a more recent study, it was demonstrated that dual energy CT and especially iodine maps can be used to achieve higher specificity while maintaining satisfactory sensitivity for determination of thyroid cartilage invasion when compared to MRI scans. So when it comes to thyroid cartilage evaluation, how do we interpret this? This is a case of non-invasion. The left panel 65 kV VMI tumor abutting thyroid cartilage. The middle panel demonstrates suppression of tumor signal but preservation of high signal of non-ossified thyroid cartilage in this cartilage that was not invaded. And the panel on the right demonstrates tumor high iodine content limited to outside the thyroid cartilage, again consistent with non-invasion. In this case, on the other hand, there is invasion of thyroid cartilage. As you will notice, the invading part follows the same characteristics as native tumor, with its attenuation being suppressed on high-energy VMIs and its iodine content being similar to native tumor on the iodine maps. Now, I would like to conclude the talk by discussing a few other applications of DECT. There are a number of studies demonstrating the utility of DECT for artifact reduction both in and outside the head and neck. In this example, note the left is 65 kV VMI. There is reduced dental artifact on the 95 kV VMI shown in panel B and the 140 kV VMI shown in panel C. However, I do need to point out that when it comes to dental artifact reduction, the effects of high energy VMIs and the impact is more variable. Furthermore, this is complicated by the fact that tumor attenuation and therefore visibility reduces on higher energy VMIs, which one has to take into considerations in terms of practical utility. So if you're looking at bone that has intrinsically high attenuation, this can be very useful. But if one is trying to evaluate tumor recurrence, there may only be modest improvement in image quality. This is one example. This is the 65 kV VMI. Now the right panel shows 95 kV VMI. This energy based on one of our studies might represent a good balance between artifact reduction and some preservation of enhancing tumor iodine attenuation. In this example, higher energy VMIs are used to better see the treatment bed, in this case where there was no recurrence. With newer technologies, MAR algorithms are being incorporated and combined with high energy VMIs, representing a very powerful approach for artifact reduction. There are some other applications of DECT. These include applications for evaluation of pathologic lymph nodes, as well as applications for evaluation of thyroid nodules. At this time, these have not demonstrated sufficient discriminative ability or practicality to be implemented clinically, but there are interesting areas for continued research. Now, I do want to discuss one non-oncologic application of DCT for the head and neck, that is for evaluation of synostosis. If you're one of those sites where a contrast-enhanced CT only is performed for evaluation of synostosis, look at this example of a contrast-enhanced CT. Essentially, I do not think it's possible to detect a small stone on this scan or discriminate it from the small vessels. Now I'm showing you on the right the virtual unenhanced image created from the contrast enhanced image using dual energy CT, which is in the middle, as well as a true unenhanced image demonstrating a small stone at the submandibular gland hilum that was not clearly distinguishable on the contrast enhanced CT acquisition. Therefore, if you have a dual energy CT scanner, make sure you take advantage of these reconstructions. Some of the applications we discussed can also be used for better delineation of inflammatory changes in different lesions. Now, as a general approach, I like to think of multiparametric approach to DCT interpretation, almost the way MRI is done, combining information from different DCT reconstructions for an optimal diagnostic evaluation of the lesion. Radiologists are used to doing this. This is what you do with different MRI sequences. Again, there's not enough time here to discuss the workflow impact, but this definitely needs to be considered, especially if you have one of the older scanners. Now, to conclude, I'll briefly discuss some future horizons and applications. There's increasing interest in the role of dual energy CT for radiation therapy applications that include predictive analytics, for example, based on iodine maps, as well as dosimetry and planning. There's also potential for combination with radiomics and machine learning for improving tissue classification and other important predictive tasks, as shown in preliminary studies performed in our laboratory. Now, in summary, in this talk, I discussed multiple emerging applications of DCT in the head and neck, and also demonstrate potential for many advanced applications. Lastly, as you can see, there's a number of new areas of opportunities for research and development, including both in radiation therapy and in combined applications with radiomics and machine learning that can be used both for better predictive modeling and potentially for workflow enhancement. I hope the talk was informative. That's the end of this presentation. Thank you for your attention.